Buenas tardes a todos. Voy a tomarme la libertad de saludarlos en español, ¿verdad? Que es mi lengua primaria. Gracias al comité organizador y al Dr. Santana por la invitación. I don't have any disclosures to report today. I was asked to speak about global challenges in treatment of hepatitis B. I think the biggest challenge will be to make this up in 20 minutes. So I'll do my best to give you, keep it simple and give you a review of the therapy. Okay, there we go. So let's start speaking. Okay, let's start speaking about prevalence. It was estimated in 2015 that over 250 million persons were infected with hepatitis B worldwide. If we compare this to hepatitis C, we would only know that hepatitis C, there's only 70 million persons infected worldwide. So the importance of this disease is unbearable. Sorry. North America and South America are considered low incidence, low prevalence regions, and the regions of more concern are those with high prevalence. These are mostly the Western Pacific and Africa, the whole continent. Sorry. Okay, so what's the burden of the disease? In 2015, hepatitis B resulted in estimated near 1 million deaths, mostly due to cirrhosis and hepatocellular carcinoma, all this secondary to the chronic infection. HCC is the most common type of liver disease worldwide, of liver cancer, worldwide. And chronic hepatitis B accounts for more than 50% of the cases. Important facts are that as of 2016, only 27 million people, or 10% of all those infected, knew or were aware of their infection, and only 4% of these patients were receiving adequate therapy. Regarding transmission in endemic areas, most commonly transmitted is from mother to child, and it is important because infection at birth and during early childhood leads to chronic hepatitis in 95% of cases. So vaccination and perinatal interventions, we will mention them because they are of vital importance to decrease the prevalence and incidence of this disease. Hepatitis B is also spread by needle stick injury, tattooing, piercing, and exposure to infected blood and body fluids. Infection in adulthood leads only to 5% of chronic infection. This is to emphasize how important these interventions of vaccination and perinatal interventions are. In the United States, just to give you historical, how it's been, by mid-80s, pregnant women were starting to be screened for antigen surface antigen. Routine immunization at birth started in the early 90s, and routine immunization for adolescents in the late 90s. This is a graph that shows you how the incidence of acute hepatitis B has progressively decreased with those interventions. And many of the countries who have high endemic must follow these guides. This graph here is from China. China has the largest burden of disease worldwide. They have made significant improvement in the last years regarding vaccination and perinatal transmission, and they were recently downgraded from a high endemic area to an intermediate area. So now their emphasis, they are targeting to reduce in 65% the mortality from complications regarding hepatitis B by 2030. They know and they've studied, and they will emphasize in these next years in properly diagnosing patients with disease. As I told you before, most of the patients affected do not know they have infection, and many of them know they have the disease once they already have cirrhosis or hepatocellular carcinoma. And once you diagnose these patients, you have to make sure you have available therapy for them or you have access for them. So what are the major interventions that are required to reduce incidence and infections and new infections and adverse outcomes such as cirrhosis and HCC? Well, prevention of neonatal and childhood infection through vaccination and perinatal interventions, prevention of cirrhosis and HCC by adequate diagnosis and appropriate treatment. I will emphasize on this a few times, because one of the main burdens of the disease probably is access to diagnosis and access to treatment. We do have drugs that are available that we will discuss, but if the patients do not have access to diagnosis and to treatment, well, that won't help out at all. So regarding treatment for chronic hepatitis B, we will try to answer these questions. I think this will guide us through an update. Okay? What patients should be treated for chronic hepatitis B? When should we start treatment for hepatitis B? What are the goals of the therapy once we start a patient on treatment? What drugs should we use? When to stop the treatment? I think that's one of the biggest questions that all the treaters have. And of course, we're going to mention special populations such as pregnant women and those patients who are undergoing immunosuppression or will undergo immunosuppression. I'm not going to try to explain the HBV cycle here. We know it's a DNA virus. And I just want to emphasize on the complexity of the life cycle of this virus. This complexity probably is the reason of why it is so difficult to treat and why a cure has not been accessible as in HCV or other conditions. So once the virus infects the hepatocyte in a capsid mode, it invades the nucleus where you have circular DNA. This DNA is transcribed to messenger RNAs. These RNAs pass into the cytoplasm, and they use the hepatocyte transcriptases for DNA formation, and this cycle can go on. Important markers or serologic markers, this is one of the main goals to follow up patients and to guide therapy. So what are the most important ones? Hepatitis surface antigen usually signifies viremia in either acute or chronic infection. E antigen usually means there's high infectivity. IgM core antibody signifies that the patient has had a recent infection, usually 6 months recent. But it's also used when patients have reactivation of disease. You may see this antibody positive as well. Surface antibody usually is immunity from vaccination or persons who have seroconversion when we treat them. And core IgG antibody is exposure to hepatitis B in the past. So what are the goals of therapy? I think the main goal of treating patients with chronic hepatitis B is prevention of cirrhosis and prevention of HCC. We know that these two conditions are lethal, and if you don't have access to a transplant center, you will die. Okay. So how do we get this? We need to improve liver histology with the therapy, or that should be one of the goals. We need to improve inflammation, and we need to reverse, if we can, fibrosis. Once the patients have advanced fibrosis or cirrhosis, reversal of this is very hard, if not possible. So we need to diagnose early and treat these patients before this happens. Another goal is to decline the DNA or to eliminate the DNA in the serum. ALT normalization, this goes with inflammation as well. And of course, the dream drugs or therapies would be those that would get seroconversion. With what we have now today, we know from the get-go that many patients to achieve this goal may require long-time therapy. The EASL and the AASLD have made classifications regarding the natural history of hepatitis B. So I'm going to use this graph to let us know what patients should we treat and explain the different classifications. I'm going to start with those who do not need therapy, who do have chronic infection. There's a group that we all know. It's called the immune-tolerant patient. These patients have very high levels of surface antigen. They have very high levels of DNA, usually above 1 million. But if you follow their labs, you'll see they have normal ALTs, and if you perform a biopsy, these patients will have no disease, no evidence of inflammation or fibrosis. The other group you can have of chronic infection are those that are called the inactive carriers. These patients have surface antigen, of course, and they do have DNA, but in low levels. And these patients, just as the other group, have normal ALTs and normal pathology. The main group to follow are those patients that do have evidence of chronic hepatitis B. In these both groups, the patients will have elevated LFTs, and if you perform a biopsy, the patients will have moderate to severe inflammation, and in cases, fibrosis. And they have a very high risk of disease progression. The main groups are divided in those that are HBV antigen positive and the ones that are antigen negative. And why is this distinction so important? Because this fact, the presence or absence of this antigen, is what will define the length of the therapy and if these patients can be taken off therapy at some moment. Just to make a difference, the only difference between AASLD, that's the society in the United States, versus EASL, that's the main society in Europe regarding liver diseases, they use the same classification. The only difference recommended therapy is the levels of E antigen and DNA. Recent update regarding the guidelines, those patients who have only mild elevation of LFTs, you should consider a biopsy, and you should consider other risk factors such as age, family history of HCC or cirrhosis, previous treatment history, and more than age, you should consider time of disease. If you estimate that a patient has been infected for more than 40 years, these are patients that you should consider treatment. Patients who have compensated cirrhosis should be treated independent of the viremia, of the levels of viremia, and regardless of ALT. So this is one of the take-home messages. Patients with cirrhosis should all be treated for hepatitis B. Those patients who have decompensated cirrhosis, this is the most advanced disease, and have an surface antigen positive, you should treat them as well. Doesn't matter if they have DNA levels, normal ALTs, they should be treated as well. And those patients who are immune tolerant that we were supposed to be following, if they have 40 years of disease and they are from high endemic areas, we should consider, even if they have normal labs, we should consider biopsy. And if they do have inflammation or fibrosis, we should treat them as well. So what are the drugs that we prefer to use or they're recommended right now? Well, the main three drugs are entecavir, tenofovir AF, and tenofovir DF. These three medications are approved for non-cirrhotic patients and compensated cirrhosis. Peginterferon may be used. It's a finite therapy of 48 weeks, and it should not be used if you have a patient with advanced cirrhosis or portal hypertension. It is contraindicated. For decompensated cirrhosis, the recommendation right now is entecavir at 1 milligram and tenofovir DF. We think tenofovir AF will do fine with them, but there's still no approval. But there is a special group of patients, those who have decompensated cirrhosis and have advanced renal disease, that might be the drug of choice as well. This is only to emphasize, as you know, in the questions I asked before, a few years ago, there would have been a slide or many slides in this conference regarding resistance of hepatitis B to treatment. That's not a fact right now because of the drugs that we use have very favorable safety and resistant profiles. But there are many countries and regions in the world that do not have access to these drugs. And the drugs that they are still using are the later generations, such as adefovir, talbudin, and lamivudine. And these patients need a different follow-up because of the resistance of these drugs. As you see, just to bring back the graph, where do the medications perform? Peginterferon does not interact with the virus. It's an immune modulator. And the nucleotides or nucleosides inhibit the reverse transcriptase, and they are very effective in in controlling the viral replication. Comparing, you know, the newest drug is tenofovir AF. When they compared it to tenofovir DF and they switched from one to the other, there was no change in viremia. So it is as effective as as tenofovir DF. The main advantage that tenofovir AF has is in those patients who have renal impairment. For patients using entecavir or tenofovir DF, those who have renal function with GFR below 50, they need to follow these recommendations regarding adjustment to dose and to days of therapy. So as you notice, there's people who can receive the drug every 72 hours. You have to combine it with or without dialysis. So in these patients, probably the way to go is tenofovir AF, and I think this is the major function of this drug at this moment. How do we follow or monitor the patients who are receiving therapy for hepatitis B? We should perform liver tests every 3 to 4 months in the first year, then every 6 months thereafter. You should follow DNA levels frequently in the first year, and then every 6 to 12 months thereafter. In those patients who started out with HBV E antigen positive, they should be followed for the antigen and the antibody as well. Those patients who start to have a non-detectable HBV DNA should be treated at least once a year for surface antigen. And if that surface antigen is negative, well, that's when you try to measure the antibody for surface, and that would be or mean seroconversion. I think the most important question of the conference probably is when and can we stop the treatment for hepatitis B? It's very easy, or usually we have no doubt in when to start a patient, but there's a lot of confusion, as we say, in who can we stop the therapy and if we can stop it at all. Those patients with Peginterferon, it's only for 48 weeks, so we don't have to question when to stop that therapy. But the patients who have hepatitis B who are on nucleoside analogs, the endpoint would be if the patient is cirrhotic and if the patient started out with E antigen. The patients who are cirrhotic should have indefinite therapy. No patient with advanced fibrosis should have the therapy stopped. We don't question it. Patients should continue on therapy. Those patients who started out with E antigen negative test, these patients should also be treated indefinitely because it's very rare that these patients have total seroconversion. In those patients who start out with the E antigen positive, we may consider discontinuation after we evidence seroconversion, but it's of vital importance consolidation therapy for a minimal of 12 months. And in this group, near 50% of the patients might continue with seroconversion. So in general, most of the patients will need to continue therapy. This is regarding consolidation. It's evidence that patients who have longer times on consolidation have a less, are going to do better, and relapses are going to be much fewer. It seems like age is important. I would probably not consider discontinuation in patients older than 40 years old if they are from endemic areas, even with consolidation. How about pregnancy? I have to, it's not on the slide, but it's the recommendations for perinatal interventions in patients who are born from infected mothers. You know the mothers should be tested for surface antigen in the first trimester. Children born to those mothers should have HPIG immunoglobulin given and vaccination, the first dose, within the first 12 hours of birth. And as you see in this, and those patients who have, the mothers, high DNA levels above 200,000, they should be treated in the third trimester with tenofovir DF. As you see in this group, none of the children that were treated with tenofovir DF developed the disease. Patients should receive therapy after 3 months postpartum, and you will have to watch for flares of ALT or disease when you take them off the medication. Breastfeeding is not contraindicated in these patients. How about patients who are undergoing or will undergo immunosuppression? All patients who are going to be submitted to immunosuppressive, cytotoxic, or immune modulator therapy should be tested for hepatitis B. What are the tests we should order? We should order hepatitis B surface antigen, and antibody to core, total IgG. If the patient has both of these tests positive, they should go directly to prophylactic therapy. If the patient has only evidence of prior exposure and no active disease, well, one could consider starting prophylactic therapy anyway. Or you could consider monitoring this patient. But you have to be very emphatic if you choose to monitor these patients. It doesn't mean to do tests every now and then. You have to be very strict with yourself, and you have to measure DNA every 1 to 3 months. And you should start therapy or prophylactic therapy in any sign of reactivation. That means DNA elevation, S antigen present, or elevation of LFTs. Those patients receiving anti-CD20 therapy or rituximab or undergoing stem cell transplantation should receive prophylaxis from the get-go. What do we use for prophylaxis? Well, we use the same drugs that we use for treatment, and they should be treated during the period of immunosuppression and 6 to 12 months afterwards. So, key take-home points. Vaccination and perinatal interventions must continue, mostly in emphasis in those countries that are endemic. I think when I started to consider how to give the talk, it said global challenges regarding treatment. Well, I think sadly the biggest challenge we have is socioeconomic barriers and access to adequate diagnosis, access to care, and of course, access to therapy. So that is something that all countries must work on. We should treat all patients who have evidence of chronic hepatitis. And most patients, we have to understand that at this point, with the drugs we have, most patients will probably need to continue on indefinite therapy. If you want to take a message that is important today, it's you treat all cirrhotics. It doesn't matter how sick they are. These patients should be treated. They are patients that sometimes come in needing a liver transplant, decompensated, and we evaluate them. They're ready for transplant, and once they start treatment, many of them improve and they don't need a transplant. Okay. The drugs, the preferred drugs, I already spoke about them, and thankfully, we don't have any resistant issues. And I didn't have time to speak about the new drugs on the pipeline. If you look at the cycle I showed you about the virus, well, there's new drugs basically all around the diagram being on the way. And we must believe that in the next years, we will be treating hepatitis B like we treat HIV, like we treat hepatitis C, with drug combinations or regimens. Thank you.